Bonjour, bienvenue
Hello, welcome to our third February within our month of February. I am Gail Ouellet, and I am the part of the RQMO. My name is Gail Ouellet, and I will introduce our topic for the month of February this year.
voilà. Notre
Our And
voilà.
as mentioned, I'm a scientific researcher here. And for the month of February this year, the theme is the Odyssey of the
Tous nos organismes sont en
non-diagnosed.
lien avec ça.
And all of our sessions and conferences are tied to
Au
this
Québec,
theme.
nos
In
statistiques
Quebec, our
qu'on utilise
statistics,
actuellement nous disent qu'on aurait
the
probablement
ones we
jusqu'à
use now,
700 000
are telling
personnes
us we have
avec une maladie
approximately up to
rare,
700,000 person with a rare disease, about 500,000 children at
c'est
one point in time.
43%
This
des
represented 40 to
diagnostics.
50% of people who are left
On dit à
without
un moment
a
donné,
diagnosis.
évidemment, il y
And
en
we
a
say
qui
at
vont
one point in time because, of course, some
diagnostics.
will obtain a diagnosis
Après un
eventually.
sondage,
And
Anita
our
a
KMO
été
held a
fondée
survey
en
when
2010.
it was founded
Il y
in
a eu beaucoup de
2010.
sondages
There were many
internationaux,
surveys held
l'Alliance des règles
internationally
rares
in
aux
Europe and
États-Unis,
the Alliance of Rare Diseases in the
l'organisation
US and the
canadienne,
Canadian organization
mais
CCOR.
récemment,
But
nous-mêmes,
we all pretty much
en
obtained the
moyenne,
same
dépendamment
findings
des
on
sondeurs
average,
qui on a sondés,
depending on the survey and who we
environ de
surveyed.
7-8 ans
The
pour un
average
diagnostic
is
rare.
7 to 8 years to obtain a diagnosis for rare disease, and 37% of our respondents said that it took 3 years or longer in order to obtain their
30%
diagnosis.
10 ans et
18%,
plus,
10 years and
30%
beyond. 30%
consulté 5
told us they
fois
consulted
avant
5
le
physicians or more
diagnostic.
before being
En fin de
diagnosed.
semaine,
Moreover, this week,
il y a aussi Rare Disease
there's
Ireland
also Rare
qui ont
Diseases Ireland. In
publié les
Ireland,
résultats de leur
they published
sondage
the
et c'est
results
très
of their
semblant dans le fond.
surveys, and again, they're very
Donc,
similar. Therefore,
j'essaie de changer.
one moment, I'm trying to move the slides.
On dit, en général, on dit qu'il y a
Generally speaking, there are two categories of
les pas
people without a
encore
diagnosis.
diagnostiqués.
Those not yet
Ceux qui
diagnosed, these are the
nous
ones
sont investigués
who are
régulièrement. On
investigated on a
consulte
regular
nos
basis
diagnostics parce
while
qu'évidemment,
believing they may come up with a
c'est difficile
diagnosis,
pour
because, of course, it's always very challenging to find a diagnosis
c'est
of a rare
c'est
disease
vraiment
versus a common disease. And out of these, they'll end up getting a diagnosis, even if it
sans
can take a few
diagnostic,
years.
c'est des
You
personnes
have
qui
those
probablement ont une
undiagnosed,
nouvelle maladie, si on veut,
and they
qui est
present with a new disease, one that wasn't characterized per
pour
se,
laquelle on
a
a fait
disease for
tous les
which
tests, examens qu'on
we've held
connaît,
all the tests and exams we know of
ceux-là, par contre,
without
avec
finding
la
anything.
technologie
And these, however, with the
séquencée
advent of
si
new
d'une maladie
genomic and genetic technology, if it's a
aujourd'hui,
genetic disease,
on en découvre de plus
today
en plus
we
sur
uncover more and more so of these diseases and are in a position
une
to
troisième
diagnose even more.
catégorie
So
qui
we also have a
sont sans
third category
diagnostic, c'est les
of
maladies
people who are not
psychosomatiques.
diagnosed. We're talking about the psychosomatic diagnosed.
Beaucoup de gens dans notre
Many
réseau de
people
santé
in our
qui,
healthcare system,
souvent avec des maladies qui
often
ont des symptômes non
when
spécifiques,
diseases present with
et ces
nonspecific
gens-là sont
symptoms,
souvent
unfortunately,
consultés des femmes.
this occurs
On
frequently
décide finalement
among women.
que c'est
And they were
peut-être
told finally that
psychologique,
it's perhaps rather
psychosocial. Et
psychological or
c'est pas
physical
toujours le cas
when
parce
it
qu'on
comes to
finit
their
par
condition. We know it's not always the case because some end up being diagnosed for rare disease.
mais c'est une réalité qui
And
existe
it
dans
is
le
a
domaine de
reality
la
that
maladie
does
rare et
exist
puis
within the realm
il
of rare
faut évidemment
diseases.
trouver des
We
façons
must, of course, find ways
des solutions aussi pour ce type
and solutions as well for this type
qu'on
of
dit somatoforme ou
disease that is
psychosocial.
referred to as psychosomatic
En
or
c'est
socioform. But the
l'effet d'un
medical
diagnostic, ben,
consequences of this
on dit
diagnostic errancy, there
même
could be
erroné ou
treatments,
souvent
even
parfois
erroneous
l'erreur
ones,
qu'on
or often it's by trial and error because we don't exactly know the disease. There are false diagnoses and treatments or surgeries, interventions, drugs that are prescribed that are not appropriate. Also, in the case of genetic diseases, we can't really provide a specific genetic consultation or advice without knowing the family history. In terms of the social aspect, there's uncertainty for these people. They are years without being diagnosed, and so there's loss of hope and or false hope. Often they have a hard time accessing services. They don't fall into the box or the category of certain services provided by the government within our healthcare system, and there's psychological distress and a loss of trust and confidence in our healthcare system. As mentioned, physicians cannot learn more than 7,000 rare diseases that we know of today. Therefore, we must adopt an approach. Moreover, we are referring to an approach that was used that is addressed in France with the first rare disease national plan. In France, they wanted to implement the culture of doubt for physicians to consider or dare consider rare diseases, because when they've held all their tests, standard tests and exams, still without a response uh, or any kind of result, and they have the patient before them, they have to try to see what more they can do to suspect or doubt that it may be psychological. They should rather refer their patient. And we think that that training should be available to physicians and other HCPs. And of course, within our network, we don't yet have a national plan for rare diseases. And we also need resources for these physicians for them to know where to turn, who to refer to, and where to seek out the information for these patients. Two examples of people. A lady took her 36 years to be diagnosed with the Ehlers-Danlos syndrome. She showed manifestations of this condition throughout her childhood and adolescence. Perhaps the solutions we'll hear about today could have helped her diagnosis with the data of her medical record. And tiny Tommy here took him 14 years. And this very, very recently, his new disease or rare disease was finally diagnosed. It's part of this category of precisely of these new diseases or those associated to a gene, but presenting it a different way. So with the new technologies, he was able to get a diagnosis. I wish to thank at the same time our sponsors that enabled us to set up and organize this entire month of activities. And I will move to the presentations. Beforehand, I would like to tell people if they have questions, they can enter their questions in the Q&R option at the bottom, or Q&A option at the bottom of the screen, Q&A in English and Q&R in French. Therefore, you may post your questions in the Q&A and not in the chat option, please, and we shall take your questions. I will stop the screen share now. There you go. I will now introduce our first conference speaker, Madam Anita Burgen. She has a medical degree. She is a physician. She also holds a doctorate in medical informatics. She is currently a professor of biomedical informatics at the University of Paris Descartes in France, and heads the biomedical informatics department at the Necker Children's Hospital and also at the Georges Pompidou European Hospital. In fact, this is the reason why she's here today. She also co-leads with Jean-François Etier of the University of Sherbrooke, the new Ensemble network for rare diseases. This network was set up last spring, and we will hear her presentation on this network aimed at improving and accelerating the diagnosis and the management of patients with rare diseases. I will turn it over to Ms. Anita Burgen. Thank you. I will now share my screen. Are you able to see my screen share, my slides? In full screen, yes. Did this work? Because we held tests and it worked earlier. I'm going to talk to you about the Ensemble network. And this is really to be able to develop a healthcare system for rare diseases, a learning healthcare system, and to provide knowledge, know-how for the management of patients, and to be in a position to provide services to patients. And this Ensemble network is Canadian, and it's spearheaded by the University of Paris in France and that of Sherbrooke in Quebec. There's also a great number of partners, and GATE is part of that partner. We already work together on how we can obtain data on rare diseases, how to treat them and diagnose them collectively all together. And the idea of building together a learning healthcare system for rare diseases is about providing a transfer between the research center and data, clinical data. And this is also to help patients in the future. And based on the different knowledge, we will be able to treat. And we have a loop such as this one in order to learn continuously. And this is why it's difficult. This will enrich the knowledge based on care data, and the data has to be correctly identified, should be used and secured for this learning healthcare system. Concretely, today, I'm working in Paris and I work with Imagine. I showed you a picture on the left, and this is located in the middle of Descartes Hospital. It's a sick children's hospital, and this is in the middle of the building, and it's called Imagine. There's something unique about Imagine. It's a learning healthcare system while making it such that way at the bottom, you see the ground floor, you will see the consultations. Patients come in with their children for a consultation to consult experts. And then there are two other floors, the first and second floors. These are floors where we work. We work on everything in terms of data collection, and we have the data speak that came back to the hospital through Imagine. The upper floors are labs to show the genetic information. Will study based on the various pathologies and the various endpoints and services that can be applied. It's totally integrated and built in, and we're trying to implement it, generally speaking, to tie the healthcare to research. To be able to do this, as I said, there's the ability to save the data in a secure manner. Therefore, in order to do this, there's a system that not to share the data to a fixed place or to send the data like to Imagine Institute or Sherbrooke University. It's not going to move, but we'll make it such that we can drive projects in a cooperative manner using all the systems and a major system that was developed in Sherbrooke by Jean-François Etier, and it's called PAR3. It will enable us to have security and an agreement to obtain the data and to entrust it to those who locally are in charge of the data. They'll be project heads, those who will have access to data, and a certain number of consultants or advice that will be established. And this is a precious flowchart. It's a major advancement in the field of research for rare diseases to have such a framework and infrastructure to secure all of the data while leading cooperative projects. This is a very important point in the area of collaboration with Jean-François and Sherbrooke University. And in terms of Imagine, what's important is to also have these locally installed systems, given that we have uh, data and it preserves about 800,000 patients, many with rare diseases. And Nicolas will speak to you about this immediately thereafter. It's a system he entitled Dr. Warehouse that will seek out information among these thousands of patients to learn from the data that is collected in the files. I'm giving you an example of what we can find in a patient's file when there's a mutation such as MECP2, and if one presents with epilepsy, we might find and uncover there's osteoporosis. And if it appears, because it appears tardively in this syndrome, we have to take the patient's history, not just after a few cycles, but also afterwards. And we're not insisting on saying that after a few years, patients will be presenting with osteoporosis. This is an important point to have all of the information that will be collected to enable us to have the full picture and as thorough as possible of the landscape to see what this mutation is all about. And we can do this for all patients who come in with Duta-Baker and to have this for all the different diseases. And it's very helpful to learn about the rare diseases. And we have many programs. These are programs to continue to uh, help us learn from the data. And there are two conditions we call cytopathies, and they target all of the cells. And there could be a portion, it could be proximal, the intermediate, and the distal sites based on the genes that will regulate the different parts of the site. We can have a large number of signs uh, that can lead to renal failure or impairment or other conditions. It could be tied to obesity. It could be multiple, and this and the clinical signs, multiple clinical signs will make it very difficult to diagnose very early. And the way we work with this learning system, with the research data on one hand and clinical data on the other, this system will review all the patients who were diagnosed and who were diagnosed for all of these pathologies. And we know their genes that were mutated. And to know all of the history of the disease, we'll be able to look at the clinical signs called phenotyping, all the clinical signs of these patients, and to be able to correlate them with the data. We have this group of patients we know full well for whom we have all of the information and who are taking part in the research for a synopathy and all of this info. And then we'll look into the data to see if we have patients who are proximal or close by, and we'll see if they represent a certain phenotype. We'll genotype them, then we'll search for the corresponding genes for these patients. And these new patients, by the interpreter, there's a great deal of echo. The interpreter cannot pick up everything, unfortunately, because the speaker is not wearing a microphone. And then we have to continue to learn, and we'll see a new diagnosed patients. That's what we're working on currently. That's what we want to set in place within the learning system. This is what we wish to generalize between Quebec, Canada, and France, with the focus on including all of Canada and all of Europe within this dynamics of research based on this. And why did we program this together? We work together on a daily basis for sufficiently so for these programs to be worked jointly. So we work ensemble in a transatlantic manner. We work jointly with the two countries using the applications on both sides. Ensemble means a multidisciplinary network. There are patients, associations, representatives from the various committees, healthcare professionals. They form a multidisciplinary team. And Ensemble, because I've taken part in meetings on databases on rare diseases in April 2018, it goes back a while, but there are people from France that are part of patient associations, but this is good because we want to make it such that ensemble, together, everybody will work and will learn many, many things, researchers, patients, and physicians. And the program aims to have a local system for the various hospitals, a unique system, etc., based on the diagram we see. And there are Quebecers. We work with them so they can process the data, and there will be an ensemble program in order to implement the system, which is cooperative, collaborative, in order to uncover rare diseases. And there's the RQMO is a major player in this program, in this ensemble program. We work together in such a way as to collect data, in such a way as to analyze and study the data collectively. We also have establishments and institutions in Quebec, such as the University of Sherbrooke, affiliated in France with Imagine Institute and the hospitals. And we can build certain research programs as such as quickly as possible. This ensemble program, there are a few keywords shown here. It is a computerized program. There are people managing the technical part of this work, digital health, in order to obtain data coming from the various frameworks and structures. We're setting in place this data sharing framework between the various countries, and we will develop artificial intelligence. More specifically, we are developing and setting up a program to find similar patients within the data. At Becker, if I see a patient that has a combination of signs, and the question that will come to mind within the Ensemble network, might there be another site wherein there is a patient that resembles my patient or is very close to my patient in the description of the signs, who might have been diagnosed? Then I'm going to send a requisition and I'm going to ask Sherbrooke, have you ever seen such a patient? Have you not ever diagnosed such a patient? Sherbrooke will answer if I've seen a patient, detected him, screened him, and I want to know if there's a variant, a gene that will also stimulate the research. In any event, we'll be able to turn to those patients who were not diagnosed in the past. And as new knowledge is learned, we'll be able to set in place a certain number of programs to diagnose certain cases that were not diagnosed in the past. And it's the achievement of the technology. We want to set in place digital twins to obtain data that represent duplication or different patient characteristics, to be able with these digital twins to develop, test a certain number of models to have a better understanding of the various pathologies and to propose adapted solutions. And this is something that has to be developed overall collectively. This is for the technology. And of course, there's a clinical portion on which we'll develop research projects. And for rare diseases, of course, we are imagining what we can do for those with mental deficiencies and who also have anomalies in other areas. And we're going to launch this. We're going to request funding together, both in Quebec and in France or Europe, and will accelerate these research programs as quickly as possible. And we're trying to have an impact on the quality of the slides, such as the mechanism. And once we're able to do this, we can have a secure access to the database. And we figure from the moment we'll uncover a drug that it could be proposed for a specific patient profile. And of course, the medication has to be intended for a certain patient subtype. And then we'll have the ability to locate patients within the network, will be able to propose things to these patients and especially propose services or drugs that could be applied in clinical trials. Of course, this is my conclusion. It could be that if we apply this to certain patients, this is why we work very closely with our partners, and we're developing these programs with patient communities on a regular basis. I will stop here on the issues. I've already introduced them during the presentation. I want to make sure we'll have the time to chat afterwards, so I'll leave it over to my colleague. I'll stop the screen share, and there you go. Thank you very much, Dr. Burgon. I will now introduce Professor Garcelon. He has a degree in agricultural engineering and then a doctorate in biomedical informatics and public health. He's been working for 20 years in the medical field. Since 2012, he's been spearheading the medical information department of the University Hospital of Rennes in France or Paris. And he's also a researcher in the INSERM team, Information Sciences to Support Personalized Medicine at the Descordeliers Research Center in Paris. He designs and develops hospital software for clinicians and researchers, among whom Dr. Warehouse, that he will introduce today, and for which he has filed an open source license in September 27. I will leave it over to you. Thank you very much for the presentation.
Alors, donc moi, je vais vous parler effectivement de Dr. Warehouse, qui était un clin d'œil à la série
I will talk to you about Dr. Warehouse, which is a wink to Dr. House that was looking for patients that presented with rare diseases with the idea of reusing hospital data. I'm not going to show you the context again because my colleague did so at the Baker Hospital and working with the Rare Disease Center. And to be able to use the collective hospital data for research and the center with this idea, when the physician sees a rotation, first thing he does is to search within his collective memory all those patients he's seen and to see if there were similar patients. Sometimes we see this unconsciously, and it takes some time to try to locate the patient to be able to make a decision on that patient. And the idea is to resort to reuse a hospital's collective memory to accelerate the research and care. And we want to use this for the purpose of research, recruiting patients, locating patients to enroll them in clinical trials, to test ideas, and will also use for the purpose of care. Due to this collective memory, I have a patient who came in 10 years ago who resembled that patient. And what did we do? What was the diagnosis? What was the solution? And there's a main barrier to reusing the data at Dicker Hospital. Hospitals in France in general were fortunate because the data is fairly computerized for quite some time. So access to data, physicians know that in specific software, their data is available, but it's still complicated to explore and to operate. And the majority of this data is in free text, and very often they're abstracts or papers that come out on this. On COVID, it was shown that 80% of comorbidities of those presenting with COVID and like anosmia or agousia was in free text. And this is even more so normal for rare diseases. When we have a patient, we don't know what he has. It's extremely difficult to check off the boxes. And free text enables us to express doubt, negation, a patient does not have such and such, and to generate new knowledge, new information on rare diseases, for example, that we wouldn't have with a box to check off. And we'll really check off things, for example, a patient doesn't present tears while he's crying and things of the sort. We have developed Dr. Warehouse within this concept to be able to integrate any type of data intelligently as much as possible, and that it may be used rapidly by physicians and not by statisticians or computer scientists, but it can be used by statisticians, and yes, in less than an hour if they were to use them. But we have 3 points. The first was to identify the patients, to simply be able to, just like a Google engine with a search engine, we can identify patients. The second category, how to search and extract data and information, will test hypotheses or assumptions. And the third type of usage, how can we reduce diagnostic errancy? I will describe all 3 usage categories to leave room for questions. Now, to give you an idea, the data we integrated, which is the most complicated phase, is to integrate data of 30 or so data sources, 30 softwares practically. We integrated 800 million reports, hospitalizations, imaging, consultations, and structural data that we were able to identify, screening or diagnoses that are coded for billing purposes, making it such that 800,000 patient cases were integrated. To give you an idea, and if you that represents 600 beds, 600 pediatric beds, and another 600 ICU beds or ER beds. And so I am using the research module, and it's textual. We see patient movement. We'll be able to find, we'll be interested in locating all those patients who often show up in the ER, and there could be something revolving around a bone disease such as osteopenia or something of the sort. And then we've come to realize that it's very much used by interns when they have to screen or conduct their tests, to also recruit patients, and also by geneticists when one presents with a pigment condition, and if there's a gene mutation of some sort, the name of which I forget, one that is tied to the target, it could be used in Becker. And we used it to locate patients that came in 10, 15 years ago that were not diagnosed at the time because the gene was unknown. And by using the search engine, they were able to locate this patient. Of course, it enabled them to test assumptions that certain physicians want to diagnose these patients, and it could be gene related, and it could be just about anything that's included in the report. Second usage code, how to accelerate the process, whether it be for the data stream or the research or the search engine. There's a great deal of negation. We can set aside a certain diagnosis, the Rett syndromes, or something else, etc. It could be Rett syndrome. And family history is very interesting. For example, a patient's cousin had Crohn's, and we'll have to develop strategies in order to exclude these cases or include them or locate them and treat them differently. And then we push a little farther, and we developed an algorithm that extracts directly from the reports all the phenotypes and And so for every patient, we have a process that will recognize these components in the text and will be able to extract them. And this is the mission of negation, to know if the patient is involved. And Anita showed you a slide beforehand on the Rett syndrome, and we'll send a requisition. One of, it could be a disease, a diagnosis of just anything that is gene related. We'll be able to locate the patient, and automatically everything will be displayed on all the findings. And then you'll have an automatic description of the population. What we also do, we can even tie the age with the report. We can get the phenotype age at the time of the report. So it's not the phenotype appearance date, but the date that it appeared in the report for the first time. It enables us to extract relevant information for certain projects. And it could be captured on another gene, another disease. The idea is to have an automatic description of the cohort. And we published work last week on a certain syndrome, and it was the Barco OJRD, and we uncovered early signs, because the earlier we uncover the signs, the earlier we can initiate treatment. And we extracted automatically 40 million medical concepts of the sort from a free text. And of a patient's case is not just based on structured data frameworks, and then we'll be able to use certain algorithms. And this will lead us to the decision-making process. The idea is to be able, based on an index, if we have a newly diagnosed patient with a new rare disease that was never uncovered beforehand, the question that will arise, how many patients have been in diagnostic errancy for this rare disease? And it may fall into the category of psychosomatic diagnosed patients that my colleague spoke to you about. And the first option is to use all the phenotypes of this patients. There could be 5, 6, 7, 8. We don't know, and use the search engine. The problem is that it could be restrictive because we won't know the phenotypes that will prove to be interesting for a similar patient group. And the approach could be based on similarity with phenotypic criteria. We'll assess the patient, the reports, and all the phenotypes contained in the report. Then we developed an algorithm, and we'll see the patient. He'll be diagnosed in medical terms that will be included in the report. Every patient in the hospital will have this too. We'll be able to calculate the criteria and see the most similar patients. We published this in a journal because we managed to find similar patients while using the phenotypes found in the reports. And in Dr. Warehouse, we have integrated, we have developed tools revolving around data collection, generally speaking, and we have many data. And when we focus here, this is a patient file, a patient case. We'll be able to publish documents and the reports. I'm not going to get into detail, but we can access these similarities, and it will post the 30 most similar patients to this patients. And we can see it both ways. We have a patient index, one that's diagnosed, one that is similar to one that was previously diagnosed. And conversely, if I have a patient, I don't know what he has, and I looked within the similar patients, if one has already been diagnosed, that could assist me in making a decision on my patient's condition. And we'll evaluate the algorithm. And if it's uncovered accidentally, if it's a rare disease, we'll have to evaluate it. And recently, last year, a Necker team in neurology used this tool, the similarity tool, to diagnose patients on genetic mutations, Cas and 1 and 2, that provokes neurodevelopmental syndromes. And this was published in the scientific journal last January of last year. Of course, we hope to develop this more generally speaking. Dr. Warehouse, in terms of hospital data, the data is in free text. We'll be able to appropriate this data, reuse the data, etc. But especially what I'm seeking, given that it's available in many hospitals, we'll be able to export patients with rare diseases or archetypes or virtual patients representing a certain type, and to be able to also help GPs in hospitals or who don't have a reference center for rare diseases, or the pediatric community, or other physicians if there was a diagnostic error, to try to recruit these patients based on these, using these tools based on the patient's reports, in order to search and seek out these warehouses in great depth. And these are my conclusions. Thank you very much. Very impressive as a project. You know, when we surveyed 300 patients, caregivers a few years ago regarding Quebec's situation for rare diseases, one thing that came out significantly, there was a wish for a common electronic file. Now we have a health file here in Quebec. Not everything is yet integrated, and it took some time, but it's moving forward. Patients were hoping for this, despite all of the discussions, ethically speaking, with regard to the risks, data risk and security risk. And patients with rare diseases hope to share. And the reason being is that they consult many specialists who do not see the signs and symptoms of the other organ systems, and especially when it's a paper file, it's very difficult. Patients were claiming our specialists do not speak to one another. If they could only see our file in its entirety and discuss it in their meetings. And that was their wish. And now this project, deep down, what I'm seeing is that this can be done through the data as such, because it could be difficult in our center. It's very difficult to set up our healthcare system to hold these multidisciplinary discussions and meetings to discuss these files, these cases, and all those non-diagnosed cases. We'd like to have a clinic for the non-diagnosed. Will it happen one day? We don't know. It's wishful thinking, but your project of using all of the data and all the files and cases, I think, will be the solution. Questions? We've already chatted in our in the Ensemble network during our discussions. We spoke of the records, the registries that are now available. They are managed by the patients themselves. They enter their own data. They enter the data and make the data available based on their, under their conditions. They decide which data they want to make available to researchers. So we have proposed, of course, that this be integrated into the Ensemble network, the warehouse or Dr. Warehouse. There are currently 150 such registries where patients can enter their own data. And these are data stemming from their medical records, but there are other data there, like signs and symptoms. They're not necessarily officially recognized. Therefore, I will ask you if you will use these. And there's another type of data. Do you use existing databases for genetic diseases or even other rare diseases and signs and symptoms? I'm thinking of OMIM, those with their clinical synopsis, or even perhaps Orphanet, the list of signs and symptoms, or other such databases. Do you also use those? So self-reported data by patients and data in databases that are more scientific. Yes, of course. Moreover, the first step we took was to compare, and we tried to retrieve the description of genetic diseases in real life, in real world, or within our hospital. And do we have know-how? It's interesting to see that the recovery was not exactly correct. There were things that were complementary in the hospital. We're not going to have the knowledge base, but some diseases are very interesting and are not yet available in FANET. And we have 15 or so patients with a description. Nonetheless, we see there are things that we'll encounter in the hospital that we're not going to have on this knowledge base. And sometimes the knowledge is a little more generic. It may give weight. So we'll clearly use systematic information searches, the tools, etc. And of course, we want to use them, but both are very complementary. And when it comes to data integration that comes from patients and generated by people, definitely we're awaiting this. We figure ultimately there'll be a way to describe the signs that could be very, very difficult to pick up. And then if we have a structured file with forms, questionnaires, and boxes to check off, this can provide a great deal. The example provided by Nicolas on COVID is a clear depiction, which means the the portions didn't appear anywhere in the patient structured files. We had to seek out in medical text all of this information, where it was collected. But while we could have had patient data telling us, yes, I have COVID and I no longer feel anything at all, it would have helped us integrating this in the disease description. And we have many databases generated and produced by the system. In the US, we're waiting, they have that in the country, we're awaiting this and waiting to see this in our country. Yes, and they were especially initiated by patient associations in the US, and we have a few Canadian ones too now. I'm thinking you referred to COVID, the long COVID, I suppose, in your country, it's very lengthy as well for the long version, the expanded version of COVID. It's not retrospective, but it's longitudinal research that is very current at the moment. And for our part, we know diseases. I was referring to the psychosomatic diagnosed, wherein people made fun of clinical signs, but these were never reported together. And physicians doubt that they fit or they go together. We hope that this will provide a better phenotyping process for certain diseases. We are waiting for your questions. I think we have one. No, apparently not. The other question, where are you at in France in terms of data access? We see everything that you did with Dr. Warehouse and at the Imagine Institute. Obviously, there was already an environment that enabled you to do that. Here we are now discussing a bylaw giving us access to medical funding for the purpose of research. Is it rather advanced where you are? Do you still have barriers to overcome? Dr. Warehouse today, we had built it as a data warehouse for care search, but it was within the perimeter of the physician. It just so happens that it's installed in the hospital and the patients see the physician in the respective departments. And then unless we go through a certain committee, some patients don't always have access. Oh, we've lost our colleague. Okay, she's going to come back. And so this is the first point. Next, if we want to move to research and go beyond what we have available and access a greater number of patients, there's an ethical committee, an entire process that is set in place, and the management organization that gives us right to access the information came out with a software that is restrictive regarding our field and realm of expertise, because we can't analyze all of the data, and there's a challenge in a certain context. We have to recontact the patient if we've uncovered a new diagnosis, but it won't be well suited. It's not yet adapted. We still need to do some lobbying to explain that it could be used for caring for the patient and research. And these two entities today can coexist separately in our system. When in the hospital, the data is available in the hospital, and we rely on PARS-3, that platform, to interconnect all of the data warehouses. And because of certain regulations, the construction of all of this is still in progress and underway. Very good. If I understood Dr. Burgen earlier, there would even be practically an international sharing process. It would be international, Canada, Europe, the US, and I suppose language is not an issue then. It depends on the research. If it's structured, no. Language won't be an issue. If it's based on free text, it becomes complicated, even if there are automatic translation systems that could work for us. I think that AI, with AI nowadays, language will be less of an issue. Of course, I believe that many patients, children's parents with rare diseases who would hope for the data to be openly accessed, of course, if secured, patients, registries, or patient associations, they'll make sure that researchers have access to the data. Of course, it'll be anonymized, but to have access to the data, because of course, to find another similar patient for whom we've already found a gene mutation, a variant, it's really the interest in order to reduce the delays involved in diagnosing patients. In fact, I believe that firstly, the solution is to just provide the information. For example, there was one patient in the hospital resembling that. And then after that, once we have the information, the physicians can call each other and that's it. And then we'll go back to what was done beforehand in terms of artificial intelligence and between healthcare providers. Yes, and the clinical work will still be necessary. And patient confidentiality, privacy, and all that will also be very important to preserve. There are many talks revolving around recontacting patients in genetics. That's often an issue. Clearly, I leave the physicians or HCPs manage that. If they, at one point, we found a patient that resembled such and such a patient or with such and such a similar disease, and then we send the information to the last physician that managed the patient. It's up to him to decide if it's suitable or not to contact the patient again. And of course, in fact, it's interesting because people who present this type of approach, there are patients who don't at all have any experience in with new diagnoses. And so some patients might think, am I going to be recontacted tomorrow to tell me that you've uncovered that I have a rare disease? I say no. And they imagine we'll be able to scan them, rescan them. And in our case, these patients are experiencing clinical challenges and difficulties, and they need to be diagnosed. We're not going to call just anybody. Sometimes I must explain what a diagnostic errancy is all about. It's not like, okay, I'm doing well today and suddenly I am presenting with a rare disease. Totally. That's why we have this month of Zebruary, because we're not certain, we're not sure that the general population, well, of course, those who are healthy are not going to use our network. Those with common diseases will be diagnosed without any issues. Anyway, well, most of the time without any issues, but we don't know to what extent or how well people know when they err for 8, 10, 20 years or their entire lifetime without knowing the name of their rare disease. But we have a great deal of hope for your projects. Yes, it's this errancy is something to work on, because sometimes one does not even suspect that it's genetic related. And that first step is very, very important. Last question, Dr. Burgen, you mentioned certain diseases or disease categories for which you'd like to hold pilot projects. Do you want to talk about that in greater detail? You're on mute. We are now putting together a pilot project on intellectual deficiencies if they're cerebral signs when imaging, and then we're going to rely on a collaboration with people in Canada. We want to set in place these systems and the capacity of Dr. Warehouse to find similar patients, and through PARS 3 to do something that won't be solely local, but that will be broader countrywide, and we'll set it in place in order to be able to find similar cases and also to learn a great deal. These patients, some were diagnosed, others not, but it'll enable us to share within a community, and we'll be able to work together to accelerate research and care for patients. Thank you very much once more for your presentations, for presenting these fine projects. And of course, the RQMO is certainly very glad to be part of Ensemble and the network, and we'll also seek out other patient associations in the future for specific diseases. I wanted to take the last few minutes to remind you that I believe we are left with 4 Zebinars for February. The next one is on a Quebec initiative related to exomic sequencing
pour justement trouver des diagnostics
to uncover diagnoses we were unable to find until now. It's interesting. Some people were able to be diagnosed, or their child was diagnosed through these initiatives. Therefore, a project in the city of Quebec, in Quebec City, and another Canada-wide. There will be a presentation on screen share, on care for rare. And it has already identified many genes and provided diagnoses to families. It's a Canada-wide initiative. We will also have the president and the CEO of the association in the US that has this self-reported data registry and has also announced an initiative to make the new sequencing technology available to patient populations looking for a diagnosis. Finally, in conclusion, our last Zebinaire will be presented by the Montreal In Vivo CEO, which is a cluster, a life science cluster here in Quebec. We're going to talk about a planning strategy here in Quebec that the government is currently discussing, a national policy for rare diseases in Quebec. Finally, we've decided to discuss rare diseases with medical students, 32 students from the Faculty of Medicine, a quiz on rare diseases, not to identify all rare diseases, but also the approach, the reality of patients with rare diseases. Finally, we'll have our educational day on Feb 26th, aimed at support, the approach, how to speak to our physician, how to attempt to speak even more so with our physician to be better supported in the area of rare diseases, how to be supported in diagnostic errancy. We're going to launch a guide in French living without a diagnosis, and there will be other testimonials. And that's our month of February. I'm seizing the opportunity to thank our sponsors that made this month of activities possible. Thank you, Professor Garcelon and Dr. Burgen, for your presentations today. Thank you.
मनुष्यवत्प्रसादेन भविष्यति न संशयः मन्त्रार्थाः सकलाः सन्तु पूर्णाः सन्तु मनोरथाः तत्पूर्णां बुद्धिना सोऽस्ति मित्राणां हृदयस्त्रयः